You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician in the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts, and Oncology Medical Director of the Dana-Farber Brigham International Patient Center. Relevant disclosures can be found with the episode show notes on Medscape.com or on the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands. Welcome to Season 3 of the Medscape In Discussion Lung Cancer Podcast Series. Today we'll discuss targeted therapies. It has been more than a decade since the beginning of the targeted therapy era started, and we've seen substantial advances that seem to be increasing in rate in therapeutic options as well as diagnostic technology. This represents an area of some of the biggest advances in oncology, and I'm excited to have a leader in the field to help us go through the recent data. First, let me introduce Dr. Julia Rotow. Dr. Rotow is a thoracic medical oncologist at the Dana-Farber Cancer Institute, where she serves as the clinical director for thoracic medical oncology and conducts clinical research in oncogene-driven lung cancer. Some of you may remember that Dr. Rotow was a guest on Season 2 of this podcast. She joined us for an episode on young adults and lung cancer, testing and treatment options for a population that does not qualify for screening. Dr. Rotow, welcome back to the Medscape In Discussion podcast.
Hi, Dr. Sands. It's great to be here today and talking about really my favorite subject, which is advances in oncogene-driven lung cancer and some of the strides we've made really in the past year, continuing to improve options for this patient population.
Well, there is a lot to discuss. So let's just jump into it. Maybe you can take us through some of the first-line data for EGFR sensitizing mutations.
Yeah, we've had quite a flood of new trials looking at various combination therapy strategies for EGFR lung cancer with one of the classical EGFR mutations, so L858R exon 19 deletion. For the last 5-6 years, our standard of care has been osimertinib monotherapy, our third-generation EGFR TKI, based on the FLORA study, which showed superiority to the older first or second generation inhibitors. But of course, now we've seen a number of first-line combination therapy regimens beginning to present data and showing positive data. And specifically, I'm going to talk about the FLORA-2 study and the Mariposa study. The FLORA-2 study was the study evaluating osimertinib in combination with chemotherapy in the first-line setting compared to osimertinib monotherapy. And the Mariposa study was a study looking at the combination of amivantamab, the EGFR MET bispecific antibody, combined with lazertinib, a different third-generation EGFR TKI, again compared to osimertinib. We'll go through both these studies in a little more detail. FLORA-2, again, that osimertinib plus chemo upfront, so platinum doublet, usually carboplatin, pemetrexed for 4 cycles, followed by pemetrexed osimertinib maintenance, compared to what has been until now our standard of care osimertinib monotherapy. And they looked at progression-free survival as a primary endpoint. And this study was a positive study. We saw improvements in progression-free survival if you gave chemotherapy upfront right from the beginning for patients with an EGFR mutation, PFS of 25 versus 16 months approximately with this combination.
First of all, what did the side effect profile look like when combining the chemotherapy with the osimertinib versus osimertinib alone?
Yeah, it's always an important consideration when we're thinking about adding upfront combination therapy. We know that some patients with EGFR mutant lung cancer will do quite well for a long time, measured in many years on TKI monotherapy. It's not always easy to predict, however, who those patients will be. Adding chemotherapy, I think we're all very familiar with the side effects of carboplatin pemetrexed. We're now adding infusions every 3 weeks to what used to be an oral regimen, and we're adding the side effects of chemotherapy. Now, those side effects are most acute in those first 4 cycles, so the first 3 months when patients are receiving the carboplatin component, and then they do drop off, as you might expect, during pemetrexed maintenance, but it is still quite a different quality of life compared to an oral agent at home in monotherapy. It does raise the question, are there some patients who should get this sort of regimen and some who shouldn't? And we can look at the subgroup analysis, for example, from the FLORA-2 study. And key feature that did come out of that subgroup analysis was that the benefit appeared to be greatest in patients with CNS metastases at baseline. So it's a much better hazard ratio with these, and it's almost a 12-month improvement in PFS in this patient population compared to only about a 6-month improvement if you didn't have CNS involvement. This likely speaks to CNS disease being more challenging to treat and the known limitations to many of our therapeutics when it comes to crossing the blood-brain barrier. And that has led me to consider this regimen most carefully in those patients with baseline CNS involvement as part of a shared decision-making conversation with my patients.
It's an important point because really the osimertinib is what we think of as being what's going to control that CNS disease the most. And of course, everybody is getting there, including in the control arm. But I want to focus a bit on that schedule as you highlighted. I agree. The first 4 cycles of carboplatin are really where there are some symptoms, and thankfully not nearly to the extent that most patients expect when they hear the word chemotherapy. But the once every 3-week pemetrexed ongoing maintenance really is a big thing for someone who otherwise could be coming in every 6 weeks or even every 12 weeks when they're really further into the regimen and doing well. Is there a scenario in which you consider dropping that maintenance? Is there any toxicity or other aspect of that you sometimes do end up discontinuing the pemetrexed and just continuing osimertinib alone?
For patients, I think education up front about chemotherapy is really important because I agree patients tend to imagine chemotherapy, especially platinum doublet with pemetrexed chemotherapy, to be a worse experience than it usually is in clinical practice, and we can usually manage toxicities fairly effectively. We're all familiar with these toxicities. But that long-term maintenance, if you're on for many, many years, it's a long time to be attempting to be on a pemetrexed maintenance chemotherapy. You can see creeping toxicities like fatigue or renal toxicity or cytopenias that can evolve over time. The trial was written as indefinite therapy, so it was meant to continue indefinitely during therapy. But we know from the actual outcomes that many patients did drop pemetrexed therapy maintenance long before they stopped the osimertinib. In fact, the average time patients were on pemetrexed on study was only 8 months before they discontinued treatment. And that fell far short, of course, of nearly 2 years average duration patients received osimertinib. So my own practice, certainly if a patient were on osimertinib pemetrexed maintenance in this sort of regimen, if they ran into toxicity issues, I would stop the pemetrexed and, of course, continue the osimertinib and monitor on scans.
That's great. So let's jump into that amivantamab combination that you also mentioned.
So this is the other big first-line combination trial we've seen read out really in the last 6 months. And this was the Mariposa study. So this is amivantamab plus lazertinib in the first-line setting for EGFR mutant lung cancer. Now, we have data from this combination in the acquired resistance setting, which I think we'll discuss a little bit more in a moment, showing activity after osimertinib resistance. Here we're looking at moving this into the first-line setting. And this study actually had 3 arms. It was amivantamab plus lazertinib compared to osimertinib as the primary comparison, and a third arm comparing to lazertinib monotherapy as well, which was nice, I think, to compare the 2 different TKIs in different arms of the study. And here it was also a positive study. Progression-free survival was better if you added amivantamab to lazertinib compared to the TKI alone. So here it was 23 months versus 16 months again. So a very, very similar hazard ratio in terms of magnitude of benefit over time for these patients. I will highlight that both the FLAURA2 data and the Mariposa data do not yet have mature overall survival outcomes. And of course, that's the outcome we're most interested in both of these studies. But here both we're talking about progression-free survival. Now, interestingly, the Mariposa study didn't show a differential in terms of magnitude of benefit based on CNS status. So, as is usually the case for all of these arms for both studies, patients with CNS disease did worse on average than those who did not have CNS disease. But here, the magnitude of benefit was similar hazard ratio with or without baseline CNS involvement.
So it is helpful that the control arms were fairly similar across the 2, and it seems like fairly similar magnitude of benefit from the experimental arms as well. What did the toxicity profile of the amivantamab lazertinib look like?
The control arms, I think, are helpful. It's always risky to be thinking about cross-trial comparisons because there are differences in trial design, differences in the modes of surveillance that were done on therapy. But we did see very similar control outcomes, which helps us when we're trying to make treatment decisions here. Now, toxicity, as before, is a consideration here. And this regimen has some similar concerns where you're adding an intravenous option to what was previously an oral first-line regimen. And this is a Q2 week infusion, so a little more frequent infusions once you're going on to maintenance. And amivantamab is a drug that we're familiar with now in the EGFR exon 20 insertion setting, but it does have a real toxicity profile with some long-term toxicities related to wild-type EGFR inhibition, specifically toxicities like skin rash or paronychia or diarrhea. as well as MET inhibitor-related toxicities like peripheral edema, reductions in albumin levels. And upfront in those first infusion, you can get infusion reactions, so you need to be ready to be able to educate patients and nurses in the infusion center about management of these in real time. One last toxicity I will mention looking at adding combination amilazertinib here is increased risk of VTE as well. So in the clinical trial, anticoagulation prophylaxis was needed. I expect in clinical practice that we'll be doing that as well.
So before we get into synthesizing all of this, of course, we have to discuss second line as well. Can you take us through some of the most relevant recent second line data, and then we'll synthesize all of it into what you would recommend as far as the course of therapy for someone with an EGFR sensitive mutation?
When we think about these first-line regimens, we look at the PFS data in isolation, but for a patient, we're talking about the series, first-line, second-line, third-line, and how can we most optimally sequence all these different regimens to get our patients the best long-term outcomes. And we, of course, measure that by quality of life, but also by overall survival in the end. Are we improving this? How are we getting the greatest effect? Right now, again, absent the overall survival data, we don't yet know, and it leads us to estimate based on what's available second line, how could we sequence these? And in the second line setting, today, FDA approved, what do we have? We have platinum doublet chemotherapy, those who got monotherapy, and that's certainly a reasonable option for many of our patients. We also have the ability to do repeat genomic profiling at acquired TKI resistance, which I absolutely encourage, because occasionally we'll pick up actionable genomic alterations like MET amplifications, like acquired EGFR resistance mutations, which may lend themselves to off-label therapies or to clinical trials. But absent that, we also have this new generation of, I think, emerging treatment options coming up for these patients, maybe for those without known acquired resistance mechanisms, which makes up the majority of these patients. And those may include, for example, amivantamab, which has applications also in the second line or later setting, as well as antibody drug conjugates, which are showing positive data in the resistance setting. So we just talked about MARIPOSA, which was the first line amivantamab lazertinib study. We'll now talk about MARIPOSA 2, and that's the second line or acquired TKI resistance setting, I should say, which looked at amivantamab lazertinib with chemotherapy, so 3-modality regimen, versus amivantamab plus chemotherapy versus chemotherapy alone. And here the chemotherapy is our standard carboplatin pemetrexed doublet. And this was a positive study, and it showed that giving amivantamab in combination with chemotherapy in acquired resistance was better than chemotherapy alone. They showed hazard ratios in the 0.4, so really a meaningful increase in progression-free survival for these patients. And I think an improvements in objective response rate, I think almost doubled from the mid-30s to the mid-60s if you added amivantamab to chemotherapy and acquired resistance. Now, interestingly, adding lazertinib on top of it, adding that third modality of treatment, which you might think would be useful for CNS control, actually did not further improve upon progression-free survival or response rates, but it did add toxicity, and there were indeed some challenges with toxicity when you start getting into those 3 modalities all at once. So this is not yet an approved regimen, but it's an available regimen that I suspect is going to be out there in the future for our patients.
So obviously your choice of the first line is going to affect your choice from the second line or even third line. How do you synthesize this? And if you see a new patient today with metastatic EGFR sensitizing mutation, how does that look like for you? What is your discussion with patients?
Yeah, it's become more complicated, this discussion. It used to be a very short discussion where I would tell people osimertinib monotherapy and we'd start the drug and I could prescribe it before the visit because I knew what I'd be recommending. Now we have a conversation, and right now in the approved and off-the-shelf setting, we have osimertinib or osimertinib plus chemo. I think we'll all be surprised if amivantamab lazertinib is also not becoming FDA approved. So I'm going to speak as if it were available off the shelf. What would I offer with all 3 of these options available? And right now, my default for most of my patients with a new diagnosis with a classical EGFR mutation remains osimertinib monotherapy. I think absent the progression-free survival data with the option to add chemotherapy or amivantamab or a different targeted agent in the second line setting, I'm still reaching for osimertinib for many of my patients. And I speak about other options and, I speak about the possibility of adding PFS benefit up front versus adding the impact of infusions or the combination toxicities as part of a discussion. Now, there are patients where I deviate from that. And I will say that for my patients with CNS involvement, particularly those patients with significant CNS involvement at baseline, my default now has become osimertinib plus chemotherapy. And I think that had a very convincing improved CNS response rate, improved CNS depth of response. It's hard to ignore a 1-year PFS advantage. So for those patients, my default has been to recommend osimertinib plus chemotherapy. I think the amivantamab lazertinib combination has compelling data, but the toxicity profile is more challenging. We're seeing similar PFS data to other regimens. And with the possibility of using this regimen maybe in the second-line setting, particularly in those patients with MET alterations in the second-line setting, I think that's where I see myself sequencing this in the future.
I ask a lot about the toxicity because when you have so many different regimens that are similar, then it comes down to what is the toxicity profile, as well as really highlighting, as you mentioned, that time in the infusion room and getting infusions every few weeks. That is in itself a toxicity of sorts, even if well tolerated. But I want to jump to something else. You highlighted the genomic testing at the time of progression and really looking for some other actionable alteration. And of course, this is extremely important and unfortunately not widely being done enough, I would say, given that in our first line data, we see that the genomic testing is not above 80%. I mean, it should be approximating 100% of all patients getting treated, really.
Yeah, it's been a challenge. Even in the metastatic setting, we don't have perfect biomarker testing. Now, some of that reflects the realities of the challenges of getting adequate samples, et cetera. So there are real life things that influence this. But even now, moving into the earlier stage setting, particularly in resectable disease, biomarker testing has become very important for two reasons. One, you don't want to accidentally give an EGFR or ALK positive patient, for example, immunotherapy as part of a perioperative chemoimmunotherapy regimen. We know these regimens are not particularly effective for these patients, and they increase risk of toxicity. The patient then needs to go on to what is the best regimen for them in a more advanced setting, a TKI. So trying to avoid giving patients, unhelpful, even harmful therapy, first step. Second, we know there are now adjuvant TKI regimens, both for EGFR and ALK, which have shown substantial improvements in outcomes that should be used post-op. So if you can find these patients, you can make sure they get appropriate or most effective adjuvant care. Now, the question is, what does it mean to do appropriate biomarker testing in the resectable disease setting? What counts as appropriate testing? Right now, the standard of care is a PD-L1, EGFR, and ALK. And those can be gotten back very quickly. You can do your PD-L1 IHC, you can do an ALK IHC, and you can do an EGFR PCR, for example. So these can return fairly quickly with fairly limited amounts of tissue. So question, should we be doing broader testing? And I think the field may be moving eventually towards more broad NGS testing because EGFR and ALK aren't the entire story when it comes to immunotherapy. Think about our other classically non-smoking associated oncogenes like RET, for example, or ROS1, where likely there are similar issues with benefit to therapy from immunotherapy. And that creates challenges related to timeline to testing, timeline to getting NGS results. So I think for our patients, solving the challenge of how do you get NGS fast when therapy can't wait because you're neoadjuvant, deferring definitive therapy is going to be the next challenge to solve.
Yeah, you're highlighting a really important topic. I think this testing is really important and how to get that done rapidly enough that you're not holding up neoadjuvant treatment and curative intent therapy is a topic that requires a lot of work at each individual site to make sure they have a path toward rapid testing. But with that, let's transition into the adjuvant setting. So we've talked about EGFR, and of course, there's an update on ADARA where we saw overall survival benefit. Can you just give us the bottom line on that and how that's impacted your practice?
Yeah, so the ADARA study, which first came out in 2020, so we're now actually moving towards 3 or 4 years from the initial data, looked at adding 3 years of adjuvant osimertinib in stage 1B to 3A resected lung cancer after adjuvant chemotherapy if the physician felt it was appropriate versus placebo. We've known now for really 3 years that resulted in a disease-free survival benefit. So during that course of therapy and at least sustained through, I think we have a 4-year follow-up now, we saw better disease-free survival with the adjuvant osimertinib. That's not surprising considering how active this drug is against the metastatic setting. That benefit was greatest in stage 3A disease, but was sustained all the way down through stage 1B. Now, the more recent update, and the update we were all waiting for in many ways, was the overall survival data. We've seen positive disease-free survival data for first-generation TKIs in the adjuvant setting, but have never seen an overall survival benefit. And here, with the osimertinib ADAURA data, there was an overall survival benefit in the overall stage 1B through 3A population. And I was already using this regimen based on the disease-free survival benefit, but having an overall survival benefit makes it easier, I think, to really advocate for patients that it's worth being on this drug, that the toxicities we do see on therapy, now potentially extending for 3 years, are meaningful and are buying them on average overall survival gains. So I think it really emphasizes the importance of patient education and toxicity management, even for grade 1, grade 2 toxicities, try to help people remain on therapy. In the long term, I expect we're going to see more of this sort of longer term TKI therapy We know there's data now, this trial ongoing looking at 5 versus 3 years, I believe, as well as data looking at indefinite therapy in the LAURA study after chemoradiation and EGFR mutant lung cancer. So I think we're going to be looking at managing patients potentially in very long term on TKIs, and therefore close attention to toxicity management becomes ever more important.
I agree. This has certainly become a part of the standard of care at this point, well established. Is there a point at which you are not adding osimertinib or leaning away from it, even if you discuss it, such as, for example, within the 1B, we certainly saw a positive result within that, but wasn't nearly to the same degree. Is there alignment with where you're starting to offer it or not?
I have to say I'm using it even in the 1B. As I agree, the degree of benefit was not as large as in stage 2 or stage 3, but there was still a clinical benefit and advantage. Now I'm a little faster to stop therapy in a very, very, very early stage, that 3.1 centimeter stage 1B lesion likely. It also, we have the decision about chemotherapy to be made in stage 1B disease, where I think there's variation in clinical practice for that 3 to 4 centimeter disease. And if I was very much on the fence about chemo, maybe in an older, more frail patient where I was already planning to start the osimertinib, that might tip me away from it. So it's impacting some of these elements of my practice in the very early stage patients.
Now, I'm just going to make a comment on Alina. This is adjuvant alectinib, very similar to the Adara design, also showed a significant disease-free survival. I think it is a drug that we've all really been using quite a bit already in the first line ALK setting. For the sake of time, I'm just going to briefly comment on it, but I do want to make a little bit of time to discuss some other newer regimens. So RAS1, we now have some new data for that. Can you just give us the quick bottom line on the RAS1 data?
In my opinion, we have right now a new standard of care in the first line setting for ROS1 lung cancer. So that's repotrectinib, which had some very strong positive data in a single arm study that came out recently. It was actually published in the New England Journal just today, so very timely. Until now, our standard has been entrectinib or crizotinib. These both produce response rates around 70%, progression-free survivals around 16 to 19 months. Both have either NTRK toxicity or MET toxicity, depending which drug you use, and variable CNS activity. When you get CNS activity with entrectinib, not seeing really CNS activity with crizotinib. Been using these for many years. Repotrectinib data, I think, substantially outperformed both of these drugs when we look at cross-trial comparisons. But based on this data, we now have a preferred new standard of care in clinic, I would consider with repotrectinib, due to the improvement in progression-free survival. And this is now included in the NCCN guidelines as one of the preferred first-line options, as well as FDA approved. So it should be available in the clinic for use as well.
Now, we also have a new regimen for BRAF with encorafenib, binimetinib. Can you just give us the bottom line on that?
Yeah, and that's another one where I've had a change in my own practice, again, in the last few months. And BRAF doing the same thing since probably back in, I think, 2017, dabrafenib, trametinib, first line. Response rate 60%, PFS a little shy of a year, but really a lot of challenges with fever on this regimen. If you've ever managed patients with these drugs, you know about half of them get pyrexia, and a reasonable fraction you end up dose modifying or dose discontinuing for those fevers. Encorafenib, binimetinib is an approved regimen for melanoma for some time. We now have positive data in BRAF positive lung cancer showing similar efficacy, but to my mind, most importantly here, a substantial reduction in the rates of pyrexia. So this has now become my preferred regimen because of the tolerability advantages here, again, with cross-trial comparison. So it's now what I'm reaching for in the first-line setting, and it's included now in the NCCN guidelines as well.
This is a wonderful advance, certainly for the toxicity profile. As you mentioned, the one thing about BRAF V600E that I'll add is that we do see responses to checkpoint inhibitors in the BRAF V600 population. And so I still lean toward a incorporation of immunotherapy. So whether that be pembro alone or chemo plus pembro based on PD-L1 expression. Of course, there are other checkpoint inhibitors one could consider. The fact that some of these patients have really incredible durability of their responses really is why I'd still consider one of those in the first line setting. But certainly this regimen is also to be considered in the first line or then second line setting in either case. We have to touch on, of course, exon 20. So going back to EGFR, which we started with, but now exon 20 insertion. Can you just give us the new standard for exon 20 with Papillon?
Yeah, so there's so much to talk about. So there was the positive data for Papillon for exon 20 EGFR mutations. That's amivantamab plus chemo in the first-line setting. And this was a positive study with substantial improvements in response rate and in progression-free survival. I think almost a double of the progression-free survival here with this regimen. So this is now our go-to preferred first-line option here. So this is now recommended in the NCCN as the go-to first-line option for EGFR exon 20 insertion mutations instead of chemotherapy or chemotherapy immunotherapy alone. So that is a change in practice for these patients.
Well, it is exciting that there is so much to talk about that we really have to just kind of breeze through some aspects of this to even make it through time. Thank you for tuning in. We've talked with Dr. Julia Rotow today. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for the Medscape In Discussion Lung Cancer Podcast.
Thanks for listening to Medscape's In Discussion Lung Cancer Podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on lung cancer.